Today we are going to start with the cardiovascular system from the Uworld notes. So let's get straight into it. The very first topic is hemodynamic changes in shock. So these are some different types of shock like hypovolemic shock, cardiogenic shock, obstructive and distributive shock, and what are the changes? We'll see them. Tamponade has clear lungs along with, okay, let's read them and then we'll go to the side information. So they're saying that in hypovolemic shock, the central venous pressure, which is on the right side, that is because of preload, it will be decreased, and that makes sense as well because in hypovolemic shock, the volume is decreased, so less volume is reaching the right atrium. Pulmonary capillary wedge pressure, left-sided preload, it will be decreased. For the same logic, cardiac index, that is left ventricular output, will be decreased. Systemic vascular resistance will be increased. It is a sympathetic response in an attempt to maintain the blood pressure, and SvO2, which is the venous oxygen content, it will be decreased. Why so? Because in shock the tissues are not getting ample oxygen, right? Because there is hypovolemia, so whatever blood is there, the tissue try to extract as much oxygen as possible. So the SvO2, that is the oxygen in the blood that returns to the heart, the venous blood that returns to the heart, will decrease. Then we have cardiogenic shock. So central venous pressure will increase in cardiogenic shock because the problem is that suppose this is the heart is not pumping like in systolic heart failure. So the central venous pressure, because the blood is pulling in the heart, right? So the superior vena cava and inferior vena cava, the blood will start pulling in them as well, and the central venous pressure will increase, right? The pulmonary capillary wedge pressure will also increase. The cardiac index will decrease because the heart is not pumping. The left ventricular output will be low. Systemic vascular resistance will increase because of sympathetic vasoconstriction, and SvO2 will decrease. Then we have obstructive shock. Now in obstructive shock, the problem is that there is some sort of external obstruction to the heart. Either it is some sort of tamponade that is not tamponade, or a fluid that is not allowing the heart to fill properly, or maybe there is some pulmonary hypertension or due to some pulmonary embolism or stuff like that. But the problem is not with the heart itself. The problem is external to the heart. So in obstructive shock, the central venous pressure will increase. Pulmonary capillary wedge pressure will decrease, but not in all conditions. In tamponade, left-sided preload is decreased, but measured pulmonary capillary wedge pressure is paradoxically increased due to external compression by the pericardial fluid. That is beautiful point. That although the pressure in the left atrium is low, not the pressure, basically the preload in the left atrium is low, but since like suppose this is the heart, and it is having pressure is being exerted from outside because of tamponade, the blood or some fluid is there, so it is exerting the pressure on the left atrium from all the sides. Although the blood is not present in the left atrium to a certain extent, or the preload is decreased, but because of this external pressure, the pulmonary capillary wedge pressure is monitored to be increased in tamponade, but normally it is decreased. Cardiac index will be low. Systemic vascular resistance will be increased because of sympathetic vasoconstriction, and SvO2 will decrease. Then we have the next thing, that is distributive shock. Now the distributive shock can be of three types, that is septic shock, neurogenic shock, or any systemic inflammatory condition if that is present in the body. That can also, like for example, burns or some post-MI inflammatory state. So even that can lead to distributive shock. The problem is with the distributive shock, like let's talk about septic shock. It is because of some antigen that is floating in the body, and that is causing a massive vasodilation throughout the body. Now that vasodilation of the veins and arteries will lead to decrease in the preload because the blood is being pulled in the blood vessels. Pulmonary capillary wedge pressure will decrease because of decreased preload. Cardiac index will increase. Now it is the only type of shock in which the cardiac index is increasing because the heart is trying its best to pump blood into the circulation to maintain the blood pressure, but it can't because of the dilated blood vessels. They're saying that cardiac index and SvO2 are usually decreased in neurogenic shock due to impaired sympathetic reflexes. So we will talk about that. Then systemic vascular resistance, that will be decreased, and SvO2 is increased. Yeah, because tissues are not perfused basically because of the massive vasodilation. Now these two parameters are decreased in neurogenic shock. Why? Because in neurogenic shock, like suppose the problem is that the vessels are dilated, the blood pressure is falling, and then as a sympathetic response the heart starts pacing up, right? But when the problem is with the nervous system, so the reflex actions of the reflex activity of the sympathetic reflex sympathetic reflex will not be there because of the interruption in the neurogenic connections. So that is why the heart rate will decrease in neurogenic kind of distributive shock, and SpO2 will also decrease in the neurogenic kind of distributive shock, uh, because of the same reason, I guess, like this. So remember that in neurogenic type of distributive shock, the cardiac index and SpO2 will decrease. The next point is about septic shock. There were some points over here. So they're saying that the tamponade has clear lungs along with Beck's triad. Tamponade same as cardiogenic shock, even though it's obstructive like pulmonary embolism. So tamponade is same as cardiogenic shock, even though it is obstructive. Okay. So the picture of tamponade is very similar to the cardiogenic shock. The next point is, like, the only difference in the cardiogenic shock and obstructive shock, like these are the ones, right? So the only difference is here and also here, but main difference is that pulmonary capillary wedge pressure is low, but for the tamponade it is measured high, right? So it looks like that. Then the next point is septic shock. So hyperdynamic phase, that is decrease in systemic vascular resistance, decreased blood pressure that leads to increased heart rate and cardiac output, that will lead to a warm shock, and this is the early phase. Then comes the hypodynamic phase, in which there is increased systemic vascular resistance, that will lead to decrease in cardiac output, and that will lead to grave deterioration, that is cold shock. So in septic shock there are two phases. First one is hyperdynamic, when there is massive vasodilation and the heart is pumping its best, and the heart rate and cardiac output are increasing, and that is going to lead to warm shock. Then in the late phase, there is systemic vascular resistance starts increasing, and that will lead to a decrease in the cardiac output, and that will lead to grave deterioration, and then even the septic shock becomes the cold shock. So septic shock, it is a form of distributive shock. Features are decreased systemic vascular resistance due to peripheral vasodilation, that will lead to a decrease in afterload. Decreased pulmonary capillary wedge pressure due to capillary leakage, which causes a decrease in preload. Increased mixed venous oxygenation due to hyperdynamic circulation, as cardiac output is increased in response to reduced systemic vascular resistance to maintain the tissue perfusion, with inability of tissues to adequately extract the oxygen. That is why the SvO2 is high in these situations. As you can see in this table, that SvO2 is, we are talking about septic shock, so it is high in these situations. Then we have the next thing, that may develop lactic acidosis from the tissue hypoperfusion. Neurogenic shock, it is similar to septic shock, but no sympathetic response, no increase in MVO2, so decreased heart rate and decreased MVO2. The features are decreased systemic vascular resistance, bradycardia, low MVO2, low mixed venous oxygenation, improved peripheral oxygen extraction due to lower flow. Okay, so when the flow rate is low, so the oxygen extraction capability increases. Okay. No increase in MVO2, and so decreased heart rate and decreased MVO2. So the difference between septic shock and neurogenic shock is that the MVO2 and heart rate are low in that, while in these situations MVO2 and heart rate are high. So these are the two differences between neurogenic shock and septic shock. Then we have cutaneous small vessel vasculitis, like this. So etiology is infection, medications, inflammatory conditions, and malignancy. Presentation is non-blanching violaceous petechiae. These petechiae can coalesce into palpable purpura. Cutaneous small vessel vasculitis. I think it is Knox-Jarman purpura that they are talking about, because that is a small vessel vasculitis, and that small vessel vasculitis present with the cutaneous non-blanching purpura. But okay, let's call it cutaneous small vessel vasculitis and move on. Hereditary hemorrhagic telangiectasia, which is also called as Osler-Weber-Rando syndrome. Most common cause of stroke in the kids. So that the characteristics are, in the CNS, they cause hemorrhagic cerebrovascular accident, brain abscess, paradoxical bacterial embolization across the pulmonary arteriovenous malformation. Mucocutaneous presentations include, like this. These are oral and cutaneous telangiectasias and recurrent epistaxis. In the lungs, pulmonary arteriovenous malformations will lead to hemolysis, and pulmonary artery hypertension will lead to right-sided heart failure. Pulmonary AVM, angiography followed by embolization if bleeding AVMs are present. Okay. So for the pulmonary AVMs, we do angiography followed by embolization if they are bleeding. Then it is a management plan. Then in the GIT, there is chronic GI blood bleeding, and For the liver, the Osler-Weber-Rendu syndrome can present with a portal hypertension and high output heart failure. It is also called as Osler-Weber-Rendu syndrome. Features are arteriovenous malformations, mucosal telangiectasias, which are ruby-colored papules that blanch with pressure. Bicuspid aortic valve. Now, normally, if you know that this is aorta, so it has a valve which is tricuspid, right? So, if due to some reason this valve become bicuspid, it is a congenital condition. It is mostly a congenital condition associated with the Turner syndrome. So, in that condition, the valve has only two cusps, and these valves are prone to calcify earlier and become stenosed earlier because the same pressure which was being exerted on three cusps is now being faced by only two cusps. So it is most common type of congenital heart disease in the adults. It may develop sporadically or through autosomal dominant mutation with incomplete penetrance pattern. Its presentation depends on the age of the patient. In younger patients, the pathophysiology is valvular leaflet abnormalities or aortic root dilation. This results in isolated aortic regurgitation. This leads to early decrescendo diastolic murmur. So it is in aortic regurgitation, the murmur is a diastolic murmur, and that is a decrescendo murmur. We have talked about that when we were doing the first step 1 session, so you may see it from there, which begins immediately after A2, which is best heard with the diaphragm of the stethoscope along the left sternal border at the third and fourth intercostal spaces. I guess it is the A2 area. While this patient is sitting up, and while the patient is sitting up, leaning forward and holding a breath in full expiration, so you have to remember this maneuver as well. In older patients, the pathophysiology for the bicuspid aortic valve, the pathophysiology is the calcification of aortic valve due to excessive wear and tear. This leads to aortic stenosis. In younger patient, the bicuspid aortic valve is associated with the aortic regurgitation because of valvular leaflet abnormalities or aortic root dilation. But in older patient, the same problem is associated with the aortic stenosis because of aortic valve calcification. Complications: dilation of aortic root or ascending aorta leads to aortic aneurysm and dissection and causes sudden death. So if this happens, like in bicuspid aortic valve, the aortic root, if it is dilated and it is weakened, so two things can happen. Like suppose this is the aorta normally, and the root has dilated. Now the dilation of the root is happening because of the weakened wall, right? So this weakened wall can rupture. That will lead to a ruptured aortic aneurysm and all the pesky complications which are associated with that, or maybe there is dissection that is within the wall of the aorta. The blood forms a second false lumen, and even that is a very dangerous condition because that can lead to hypovolemia and a lot of other complications for the patient. So then we have this thing. What is that? Transesophageal echo. Little invasive and special person needed to do it. So in this technique, you can see the doctor places the transesophageal echocardiogram probe into the mouth and down the esophagus. This is the esophagus over here. The TEE probe in the esophagus probe can also be placed in the stomach. Sound waves create picture of the heart, and here we have the stomach, and patient lies on the bed on the left side. Heart, atrium and ventricle. I suppose if I could zoom it in. So here you can see that the probe is present here in the esophagus, and that is picturizing the heart, which is present exactly anterior to that. And immediately anterior to the esophagus, we have the left atrium, which is depicted in the picture. So this is the atrium, left atrium, this is the left ventricle, and then we have this right ventricle and the right atrium. So this is how it works. In this picture, you can see transthoracic echocardiography. The patient lies on the bed on the left side. Sonographer moves the transducer on the patient's chest. This is the heart. Electrode patches attached to the chest for EKG, and computer for recording the echocardiographic findings. Then we have chronic aortic regurgitation. Now, the chronic aortic regurgitation, we have seen a condition that was bicuspid aortic valve, which can lead to aortic regurgitation in young adults. In chronic aortic regurgitation, the common etiologies are congenital bicuspid aortic valve, post-inflammatory like rheumatic heart disease and endocarditis. You must remember that the rheumatic heart disease most commonly affects a mitral valve and causes mitral regurgitation, but to some extent it can also lead to chronic aortic regurgitation as well. Or aortic root dilation like in Marfan syndrome or syphilis. Marfan syndrome is a connective tissue disorder, And syphilis is a sexually transmitted disease, but this causes the obstruction of vasa vasorum, which leads to pre-bark appearance of the aorta, and that will lead to aortic root dilation. Pathophysiology: backflow of the aorta, backflow from aorta into the left ventricle, that will lead to increased left ventricular and diastolic volume. Left ventricle initially compensate by eccentric hypertrophy. So eccentric hypertrophy is the one in which the sarcomeres are added in series, and the total volume of the, or the total size of the ventricle is increasing. The total luminal size is increasing. That increases the stroke volume and cardiac output. Eventually, left ventricular dysfunction, that will lead to decreased stroke volume and cardiac output, and ultimately heart failure. The clinical findings are diastolic decrescendo murmur, widened pulse pressure, that is increased systolic blood pressure and decreased diastolic blood pressure, rapid rise, and rapid fall, that is water hammer pulse will be there. Abrupt carotid distension and collapse, which is also called as pulsus parvus et tardus, and pistol short or femoral pulses will be seen. Along with that, we can also find a characteristic head bobbing, which is called as a De Mussé sign, and Quincke pulses, which are pulsations which can be seen in the nails, in the nail bed. Then aortic regurgitation. This is a beautiful picture. Like this is the S2. So after that, we have a downward slope or decrescendo murmur. It will be a blowing decrescendo murmur in the diastolic period. Then pulsus bisferens. So it is aortic regurgitation versus I'm sorry, I'm really sorry. I actually messed it up. Abrupt carotid distension and collapse is not pulsus parvus et tardus. It is pulsus bisferens, I guess. It is also called as the biphasic pulse. Okay, it is not called anything. Actually, the pulsus parvus et tardus is associated with the aortic stenosis. We are right now talking about aortic regurgitation. So this is the phenomena here is, let's suppose this is the aorta, and from the branches of aorta, we have the brachiocephalic artery. Brachiocephalic artery is going to give rise to subclavian artery, and then common carotid artery, which will branch to internal carotid and external carotid artery. And over here, we will get the carotid artery and subclavian artery like that. So the problem is that the valve which is present over here, the aortic valve, it is not patent, and it is regurgitant valve. It is, there is insufficiency, and the blood falls back. Now, to maintain the blood pressure, there is eccentric hypertrophy that will lead to the heart will try to push the blood harder into the circulation. So the systolic blood pressure rises from 120 to maybe, suppose this is a supposed value, maybe 160, right? So there is a rapid flow of blood into the aorta. So that will be detected in the carotids when we feel them, right? And then immediately after that, since the blood is falling back, so diastolic blood pressure, instead of 80 normal blood pressure, it falls down. So suppose that it is 50, right? So since it is falling back, so there is rapid collapse of carotids as well. So this rapid distension, rapid collapse of carotids is seen in this thing what we call aortic regurgitation, and then that also accounts for increased pulse pressure. Normally the pulse pressure is 40, like 120 and 80, so difference is 40, and over here you can see that 60 plus 51, the pulse pressure is 110, right? 50 plus 60, yeah. So it's too huge. Moving forward, the aortic regurgitation of pulses by pulsus bisferiens. So biphasic pulse refers to two systolic peaks of the aortic pulse from the left ventricular ejection separated by the mid-systolic dip. It is seen in aortic regurgitation, hypertrophic cardiomyopathy, and large patent ductus arteriosus. Now this is a murmur, crescendo decrescendo murmur of aortic stenosis. So initially it rises and then falls down. So crescendo decrescendo murmur. It is defined as valve area less than 3 cm square. It is most commonly caused by the age-related sclerocalcific changes in the aortic valves. Features of aortic stenosis become symptomatic when the valve area is less than 1 cm square. This value is very important. Like we define the aortic stenosis by a valve area of less than 3 cm square, but it becomes symptomatic when the valve area is less than 1 cm square. The symptoms are exertion. On exertion, there will be exertional symptoms. Like on exertion, there will be chest pain, dyspnea, dizziness, and syncope. Delayed and diminished carotid pulse, that is pulsus parvus et tardus. Slow rising pulse takes time. Now the phenomena here is like, suppose these are the carotids on each side, like this. Okay, I'm not drawing the. Okay, let's draw the log connection. This is aorta, and aorta is giving brachiocephalic trunk, which is giving subclavian artery and the common carotid artery here, and here we have the carotid artery, and then this is the subclavian artery. Now, since this aortic valve is stenosed, the blood flow through the aorta is slow, like blood reaches the carotid slowly. So the carotid pulse is slow to come. It is weak pulse and it is also slow to rise. So this is called as pulsus parvus et tardus. Now the next thing is where is it? Yeah, I'm sorry. So single and soft S2. The S2 sound will become soft because the cusps are not, the S2 hard sound comes because it has two components, A2 and P2. So when the cusp of the aortic valve, shut close over each other, that produces a sound. Since they are not even opening properly and not closing properly because they're stenosed, they're thickened, that produces a softer S2. And audible S4 sound will be there. So what is audible S4 sound? S4 sound comes in any situation wherever there is thickened or hardened ventricular wall in the cases of diastolic heart failure, right? So it sounds like a stiff heart. It comes immediately after S1, immediately before S1 during the diastolic period. So there will be an audible S4. Crescendo, decrescendo systolic murmur in the right intercostal space with radiation to the carotids. The radiation is very important. Left ventricular hypertrophy does not occur until the valve area is less than 1 centimeter square. So there will be left ventricular hypertrophy, that will be perceived as audible S4, like this. Physical examination: increased intensity of apical impulse, narrow pulse pressure. Okay, the pulse pressure will be narrowed. Why will? Okay. So this is a very important point, that in the aortic regurgitation, we just talked about the widening of the pulse pressure, right? And in this situation, the pulse pressure will narrow down. Okay. Because systolic pressure is not enough in this situation, right? So the systolic pressure and diastolic pressure will come close to each other, and that will create the situation. I think that is the explanation to the narrow pulse pressure. Then systolic murmur, a crescendo decrescendo murmur will be heard. Early peaking systolic murmur, murmur, and mild to moderate aortic stenosis. Okay. So, my mouse is not working. Yeah. So early peaking murmur suggests mild to moderate aortic stenosis, and if it is late peaking systolic murmurs, it suggests severe aortic stenosis. And pulsus parvus et tardus. This is S1 heart sound, and here we have S2 heart sound, right? In this picture, you can see that it is peaking midway. If this peak comes later, like here, so it means that it means that the situation has become worse, because the peak is when the maximum flow of blood is moving through the stenosed aortic valve, right? If it takes if it is coming late, it means that the cusps are not letting any blood in the earlier phase, so the ventricle has to push very harder, and the peak is coming all the way over here. So it means it suggests a severe condition. So I was saying that this is S1 and this is S2. Now we are talking about the peak of the murmur in the aortic stenosis. If it moves closer to the S2, so the situation is worse. Same is true about another condition. Now forget about aortic stenosis. Now I'm talking about mitral stenosis. In mitral stenosis, the murmur is basically opening snap. There is an opening snap followed by a diastolic rumble, right? And that is a diastolic murmur. If this opening snap moves closer to the S2, that indicates severer or worsening mitral stenosis. I just picturized that over here to tell you that it is S2. The close proximity to S2 indicates worsening of the condition both in aortic stenosis and mitral stenosis. If the peak of the crescendo decrescendo murmur moves towards S2, the aortic stenosis is getting worsened. And if the opening snap of mitral stenosis moves closer to S2, it means that the mitral stenosis have worsened. Okay, now moving forward, we have the diagnosis. How do we make the diagnosis? For diagnosis, we have transthoracic echocardiogram. Echocardiogram and transthoracic echocardiogram, it is very important investigation or diagnostic finding, and very important investigation technique when as far as CVS is concerned. So you will find it in a lot of places. Differentials include hypertrophic cardiomyopathy, but in hypertrophic cardiomyopathy, although the murmur is crescendo decrescendo, but there is no radiation to the carotids. Murmur is heard best at the left lower sternal border. Okay. And while in this situation, it is for the aortic stenosis, it is heard best at the left upper sternal border in the A1 space. Then we have the next topic, that is subvalvular aortic stenosis. So the problem is not in the valve, the problem is in the outflow tract. So it is the second most common type of aortic stenosis. It usually refers to the congenital left ventricular outflow tract obstruction due to discrete or diffuse narrowing of the ascending aorta. The features are mid-systolic murmur, best heard at the first right intercostal space. There will be unequal carotid pulses, different blood pressure in upper extremities, and palpable thrill in the substernal notch. The complications are left ventricular hypertrophy, high voltage QRS complexes, and lateral ST segment depression and lateral T wave inversion. Coronary artery stenosis can also occur because the point of stenosis is actually the point of origin of coronary arteries. So even they may also become stenosed. Then we have pulmonic stenosis. Features are now similar to the aortic stenosis. If the pulmonary artery valve becomes stenosed, so that is pulmonic stenosis, and the murmur is also very similar, but that will be heard at a different location. The pulmonic ejection click, a high-pitched sound after S1, best heard during expiration. Okay, during expiration. Why during expiration? Because if it is pulmonic stenosis, so all the right-sided murmurs are exaggerated during inspiration. So why is this exaggerated during expiration? Pulmonic ejection click, that is high-pitched sound after S1, best heard during expiration. Okay, so crescendo decrescendo systolic murmur, best heard over the left second intercostal space. It increases with inspiration. Yeah, as I was saying that all the right-sided murmurs increase with inspiration because of increased preload. So what is this saying about? Like, what is high-pitched sound after S1 that is best heard during expiration? I just didn't get it. It is true that it increases with inspiration because when we inspire, there is more flow of the blood towards the right side of the heart because of increased preload, and that causes increased flow of the blood from the stenosed pulmonic valve, and that will increase the intensity of the murmur. There will be widened splitting, which is further increased during inspiration. Do you remember that which condition has a characteristic wide fixed splitting? That was ASD, right? And now this is the second condition, that is pulmonic stenosis, which is widened fixed splitting. The pathogenesis of wide fixed splitting is same in both conditions. Now, the problem is that suppose this is S1 heart sound and the S2 heart sound has two components. This is A2 component and this is P2 component. A2 component comes because of aortic valve closure, and P2 component comes because of pulmonic valve closure. Now, during inspiration, like when we are during expiration, both of these sounds are very close to each other and they are perceived as one sound, right? Because when we are expiring, the preload to the heart is decreased, the P2 sound comes earlier, and there is more blood flow towards the left side of the heart, so the A2 sounds move a bit later. So both these sounds come close to each other and the split is gone. While in case of inspiration, I'm talking about physiologic condition. When we are inspiring, so there is more blood flow to the right side of the heart, so the pulmonic valve closes a bit later, and there is decreased blood flow to the left side of the heart, so the aortic valve moves. Aortic valve closes a bit earlier, so that creates a split. Now there is a cyclical change with inspiration and expiration in this splitting sound. If the split is gone, if the now normally the split must be present during inspiration and should be gone during expiration. But if there is split that is present during both inspiration and expiration, that is called as fixed splitting, and there is a wide fixed split, which means that during both the cycles of respiration we will be hearing the split. Why does that happen? In case of pulmonic stenosis, this is the pulmonary artery, the valve is stenosed. So the heart is getting a harder time to push the blood into it, so it takes longer, and the cusps come and adhere to each other after a long time, both during inspiration and expiration. So the split is wide and also fixed. It will be present during both the cycles. In case of ASD, suppose this is a heart and these are the atria and these are the ventricles, so there is an open atrial septal defect. In atrial septal defect, more and more blood is moving from the left atrium to the right atrium. This is moving to the right ventricle, and again increased quantity of blood is flowing into the pulmonary artery. Now when more quantity of blood, more than usual quantity of blood is moving into the pulmonary artery, the pulmonary valve becomes thickened and also becomes stenosed. So the wide fixed splitting of ASD is also because of the pulmonic stenosis. So that was the point I was trying to highlight. The pulmonic valve stenosis, the etiology is congenital, usually isolated defect, rarely acquired, for example, by carcinoid syndrome. Okay, we'll talk about the pathology of carcinoid in detail in the GAT sessions, but inshallah, but right now just remember that carcinoid syndrome is a tumor that is present in the GAT. If it is metastasized to the liver, it starts producing a lot of serotonin and other chemicals, and they can grow vegetations on the cardiac valves, especially the right-sided valves, and they can also lead to pulmonic valve stenosis. The clinical presentation is it will be severe, right? If it is severe, the right-sided heart failure in childhood. For the mild disease, symptoms like dyspnea in early adulthood, crescendo decrescendo murmur increases on inspiration, and systolic ejection click, for example, in widened spirit on S2. Diagnosis is with echocardiography. The treatment is with percutaneous balloon valvulotomy, which is preferred. Balloon just dilates it, and surgical repair in some cases should also be performed. Then the next topic is about the mitral stenosis. We'll continue with the mitral stenosis in the next session. So until then, Allah Hafiz, fi amanillah, and take care.